This session will begin shortly. This session will begin shortly.
Well, good morning, everyone. My name is Mairead O'Driscoll. I'm the CEO of the HRB, and on behalf of the HRB and our partners, Evidence Synthesis Ireland, Cochrane Ireland, and Team RN, I want to welcome you to the HRB's conference for 2020 on Trust and Truth in Health Research. So not only is this our first collaborative national conference, it's the first time we're doing the conference online. So it's a new format. We're all a little nervous about that, but I think you're all going to enjoy it. The great advantage of being online is that many, many more people are able to join us this year compared to previous years. We have well over 700 people registered, which is fantastic. So we're absolutely delighted that so many of you are able to join us for the next 2 days, and I'm really looking forward to your input. Now, before we get started, I have to mention some bits of housekeeping. There's always housekeeping with these things. First of all, if you have any difficulties, any technical difficulties, live support is available, and it can be located in the top right-hand side of your browser. Very, very importantly, because we're going to be having panel discussions and Q&As, the live Q&A is available on the right-hand side of your screen, and questions can be submitted throughout the session. There's a live speech-to-text available in the session information button, and again, that's on the right-hand side of your screen. And then we also wanted to mention there's a number of exhibition stands in the exhibition hall on the right-hand side of the main timeline. The exhibition is open for live chats 15 minutes before and 15 minutes after each session. But outside of these hours, you can still browse through brochures and watch their videos. And we really would encourage you to network with other attendees through the meeting hub. That's also on the right-hand side of the main timeline. And finally, don't forget to download the conference mobile app to view full agenda, speaker information, exhibitors, and lots more information. Now, the theme of the conference this year is trust and truth in health research. And of course, this is really topical right now as we are all living through this global pandemic and the sheer volume of information about COVID that we're all getting every day. And as we know, not all of it accurate. But the whole problem of misinformation about health research has been around for much longer, whether we're talking about misleading statements about vaccinations or people making claims about products, peddling bizarre cures. It's not a new problem. Some of you might be old enough to remember a time in Ireland when some people thought that the seventh son of a seventh son had healing powers. But regardless, misleading information is not a new problem. But I think what is new now is the sheer volume of information that we're bombarded with and the speed of communication, particularly in the social media age. Information and disinformation spreads so quickly, it often takes on a life of its own. So what we're seeing is ever increasing amounts of information coupled with very fast communication. And that's quite a toxic mix. Now, for those of you who are familiar with our work here in the HRB, you'll know that the whole issue of trust in health research is a topic that we've been concerned about for a while. And in an organisation like ours, which is committed to supporting high quality research and evidence, promoting the use of that research to inform policy and practice, we're acutely conscious, firstly, of the need for people to have evidence that they can trust to make good decisions about health in all walks of life, whether it's policy, practice, or even personal decisions. But we're also very conscious of the need to understand the factors that influence people's decisions and the importance of using that understanding to challenge misinformation and support people to make the best decisions and to make informed decisions. So that's what this conference is all about. We have a really great program lined up for you over the next 2 days, looking at the whole issue of trust and truth in health research from different perspectives. But to get things started, I'm especially pleased to introduce the Minister for Health in Ireland, Stephen Donnelly, TD, who sent us this address to open the conference.
It's a real pleasure to be here today for a conference that's focused on ways to build trust and truth in health research. Good health and healthcare depend on people making well-informed decisions. A part of this is giving people reliable information from a source they can trust. Over the past 2 decades, government investment and commitment to research has led to significant improvements in Ireland's health research system. Our plan for living with COVID-19 acknowledges the crucial role of research and innovation to inform and shape our public health and policy responses. COVID-19 has shown us all the critical role research plays in providing reliable information to inform policy. We're a small country, but our research contribution has been significant. Researchers here are leading and contributing to clinical trials and a wide range of other research and evidence to inform decision-making. Along with the pandemic, we've seen an infodemic. There's been an overload of information, a lot of which has been unreliable. We've seen examples of this in relation to the use of vaccines and on unproven medicines and treatments. This has exposed people and populations to the risk of using health interventions that are harmful or not using those known to be of benefit. So this conference comes at a crucial point in terms of dispelling myths and ensuring people know how to discern fact from fiction. I congratulate the Health Research Board and their partners, Evidence Synthesis Ireland, the HRB Trial Methodology Research Network, and Cochrane Ireland for bringing together more than 700 people over 2 days. The conference will raise awareness and understanding of misinformation and disinformation and its consequences. It will explore the solutions available to everyone for assessing the credibility of any health claim and to become aware of trusted sources. And finally, it will delve into the responsibilities on everyone to ensure integrity in reporting and sharing health claims. Involving public and patients as contributors and as decision makers is central to the success of ensuring information is clear, reliable, and understood. It's refreshing to see that we had their involvement in both the development of this programme and also within the programme itself. I'd like to thank Deirdre McLaughlin and Anne Daly for their invaluable contributions. We need informed decision makers and we need an informed public. To ensure people are informed, we must ensure we invest in research to generate reliable evidence and educate people so they know how to distinguish fact from fiction and challenge myths when they arise. I see this conference as a stepping stone in our journey to achieving this. I know the Health Research Board and its partners will continue to lead in the generation and promotion of understanding of reliable information in the healthcare sector. Thank you so much for all your work.
And thanks very much to Minister Donnelly for his message of support. We really appreciate it, especially at a time like this when we know everybody is so incredibly busy. Now, moving on, our first session today is all about understanding health information and disinformation. And what we're focusing on here is how to recognise reliable claims, think critically, and make more informed decisions. And the way the session is organised, we're going to hear from 3 excellent speakers, and then we're going to follow up with a discussion, a moderated discussion, and a Q&A with the panel. Don't forget that you can submit your questions throughout the session on the right-hand side of your screen. So you don't have to wait till the end. You know, if you hear something that interests you, something occurs to you, you can put your question in or indeed just your comment in on the right-hand side, and we'll be able to pick that up. So to begin, I'm delighted to introduce our first speaker. I'm really privileged to introduce our first speaker and our keynote for this session, and that's Sir Iain Chalmers. Iain is co-founder of the Cochrane Library and coordinator of the James Lind Library, and his particular interest over many years now is in how flawed ethical analyses have undermined the need to reduce uncertainties about the effects of treatments. I'm really looking forward to hearing his talk. So here is Sir Iain Chalmers.
Thank you, and good morning, everyone. How come that someone as old as I am gets invited to give the opening presentation at this important HRB conference on trust in health research? It's because Declan Devane lured me out of retirement by telling me I could use my 30 minutes on any topic I wanted. I've been concerned for 52 years about the way that flawed ethical analyses have undermined the need to reduce uncertainties about the effects of treatments. I approach this issue from the perspective of a patient and a citizen, but informed by what I learned as a health professional. Although my frequent appeals for better ethical analyses have had no discernible practical effects, I invite you to join me in considering the following question, which is on my first slide. So the question I want you to join me in addressing is, can unaccountable research ethics committees be trusted to help protect patients and the public? This booklet was produced by the General Medical Council in the UK as guidance for doctors towards good medical practice. It contained this statement within it. You must work with colleagues and patients to maintain and improve the quality of your work and promote patient safety. In particular, you must help to resolve uncertainties about the effects of treatments. Let me give you one example of the kind of uncertainty which has influenced me. Way back in the 1950s, in fact, beginning in the 1940s, it was believed by some people, on the basis of actually very unsatisfactory evidence, that if women who'd had miscarriages previously in pregnancies or stillbirths were given a drug called diethylstilbestrol, that the outcome of their subsequent pregnancy could be improved. Now, there were 2 reactions to this claim. One was by obstetricians who did controlled trials which found no evidence that this was a useful treatment. Other people carried on regardless. The first group obviously gave up giving it because there was no evidence that it was useful. Lots and lots of women were exposed to this drug, particularly in North America, but also in the British Isles. And it wasn't until the late 1960s that it turned out that this drug was causing cancers in the female fetuses, female babies of women who had taken the drug. Devastating. Now, I'll come back to this statement and this particular example a little later on in this talk. Just want you to bear that one in mind. Now, the question I ask is, ethicists and research regulators should also help to address uncertainty about the effects of their treatments, their working methods, and their prescriptions and proscriptions for others. Just like health professionals should do for their prescriptions and proscriptions. Back in 2007, an article was published in which I concluded that ethicists and research regulators had contributed to the avoidable suffering and deaths of millions of people, the vast majority of whom had not been participants in research. In an article published in the BMJ 11 years earlier, a medical ethicist, the chair of a large research ethics committee, and I posed the following question. Are research ethics committees behaving unethically? The first issue that we brought to the attention of our readers was that research ethics committees are behaving unethically by endorsing new research which is unnecessary. That was our first charge. And this is the plot that we used to illustrate why we made this point. This shows the results of totting up with each new trial the data concerned with testing whether antibiotic prophylaxis reduced perioperative deaths in people undergoing surgery for colorectal cancer. And what you'll see is that by the mid-1970s, there was fairly confident evidence that this was a useful treatment. And it could have been questioned why any further trials were done. In fact, 10 or a dozen more trials were done. Why did the ethics committees who were considering whether these trials should be done, why did they approve of withholding what was by that time a very promising, if not important, treatment prophylaxis for colorectal surgery, and allowed, in essence, half of the women in those trials to be treated only with a placebo? That's the fundamental question. This is another example of a cumulative meta-analysis, this time for thrombolytic therapy for people having heart attacks. And there again, you'll see that from the mid-70s onwards, there was really very confident evidence that this was a life-saving treatment for people having heart attacks. So what were the ethics committees doing, approving all these subsequent trials? Would any of the members of those ethics committees be happy to be assigned to placebo if they had a heart attack? So verdict number one is that patients are exposed to unnecessary risks in studies that haven't taken account of systematic reviews of existing evidence. Limited resources for research continue to be squandered on unnecessary research. And my challenge is, are ethicists and research ethics committees reducing these problems? We made two recommendations in our paper to deal with this particular problem. First one, require systematic reviews of existing research before approving research. And second, require that a summary of relevant systematic reviews be made available to potential participants in those trials. Second charge concerned the fact that research ethics committees are behaving unethically by acquiescing in biased underreporting of research, which they have approved. Note, biased underreporting of research was recognized by an Irishman more than 3 centuries ago. Here he is, looking very dogger in his beautiful clothes, Robert Boyle, and you'll see down at the bottom there a reference to a lovely article in the James Lind Library by Dorothy Bishop and Iain Gill from Waterford. He said this: "Many excellent notions or experiments are by sober and modest men suppressed." And needless to say, he thought that was a bad practice. Here's an example of the costs of biased underreporting of research. It concerns antiarrhythmic drugs in heart attack. It was written up by Cowley and his colleagues, who deserve a great deal of credit for being straightforward about this. They said, when we carried out our study in 1980, many years earlier, we thought that the increased death rate that occurred in the drug group was an effect of chance. The development of the drug was abandoned for commercial reasons, and this study was therefore never published. It's now a good example of publication bias. The results described here might have provided an early warning of trouble ahead. What trouble ahead? At the peak of their use, these drugs have been estimated to have caused between 20 and 70,000 premature deaths every year in the United States alone. There continues to be underreporting, biased underreporting of controlled trials on a massive scale. By that, I mean that 1 in 2 trials that have been done don't get reported in public. Now, I've shown at the bottom a bar which shows that this need not be the case. This is, in fact, the trials supported by the UK Health Technology Assessment Programme, and it shows that virtually 100% have been reported. So verdict 2 is that patients and research participants continue to be exposed to avoidable risks as a result of biased underreporting of research. Limited resources for research continue to be wasted because of this. Again, are ethicists and research ethics committees reducing these problems? We made 3 recommendations concerning this particular issue. Require registration of clinical trials at inception as a condition of approval. Require a commitment by investigators to make the results publicly accessible as a condition of approval, and audit the reporting of results of research previously approved by the research ethics committees. Third charge, some ethicists and research ethics committees are behaving unethically by promoting a double standard on informed consent to treatment. Here I want to read for you a paper that I co-authored with an American pediatrician called Bill Silverman in 1987. We wrote, there's another more pervasive way in which double standards operate to promote poorly controlled experiments on uninformed patients. Illogically, and with no empirical evidence to support it, a mischievous view has been promoted that the interests of the vast number of patients involved in the poorly controlled experiments of informal medical tinkering are less in need of protection than are those of the relatively small number of patients who are involved in planned, properly controlled clinical experiments. That brings to mind the diethylstilbestrol example again. So the consequences of this double standard are, as Richard Smithles, a British pediatrician, said in 1975, I need permission to give a drug to half of my patients and a control group, and control preparation in the other half, but not if I want to give it to them all, not if I want to give the drug to all of them. This confusing real-world situation, John Lantos, a medical ethicist, said, seems to reflect a confused ethical analysis. Images and language reflect and promote the flawed notion that providing treatments within controlled experiments is inherently riskier than providing the same treatments in routine clinical practice. So like this cover of Time magazine said, how medical testing has turned millions of us into human guinea pigs. The guinea pig analogy became famous in a book published in 1967 by Maurice Papworth, a British doctor, and was the principal stimulus for the creation of research ethics committees in the UK. Let me be clear, the book drew attention to some scandalous examples of unethical experimentation, mainly preclinical research, and it caused quite a stir. Now, a few years later, a decade later, he wrote in the World Medicine, a wonderful magazine, which is now defunct, about the functions of medical ethics committees. I responded to his article by saying, I share much of Dr. Papworth's concern about medical experimentation. However, I'm not so sure as he seems to be that the medical world could be neatly divided into clinical experimenters, the bad guys, and altruistic clinicians, the good guys. It seems very possible to me that there is a more urgent need to protect patients from the uncontrolled experimentation, which characterizes much, quotes, accepted medical practice by altruistic but scientifically uncritical clinicians. No response to that. And then when another decade had passed and he wrote this article for the BMJ called Human Guinea Pigs, A History, I went in to the correspondence columns again, drawing attention to his use of the words experiment and experimentation. And I tried and pointed out that I had many years previously tried to encourage him to clarify what he meant by these words. And then in this letter that I sent, it's not shown here, I used the diethyl stilbestrol, the DES example, to ask this question: who behaved more ethically? The doctors who had done controlled trials of diethyl stilbestrol and abandoned the use of the drug when they found there was no evidence that it was helpful, or those who continued to use it despite the lack of good evidence that it was useful, only to find that it had been causing intergenerational cancer and other problems. I went on to say the specific example is unimportant, but the general issue that it illustrates is one which many medical ethicists seem unwilling to confront straightforwardly. Influential commentators on medical ethics, like Dr. Papworth, owe it to those of us who have been asking them to justify their apparent double standards for more than a decade to explain their position more clearly. This medical ethicist, Richard Ashcroft, said, for ethical as well as scientific reasons, when there is properly informed uncertainty about the relative merits of alternative treatments, the trial itself is the treatment. One of the consequences of the double standard on informed consent to treatment is hyperregulation of research. Clinical researchers are being strangled by red tape. Consequence is this, from a double standard. This is from a paper published in one of the Christmas issues of the BMJ, in fact, the 2001 Christmas issue of the BMJ, in co-authorship with Andy Oxman and David Sackett. So you've got basically two models here. You have the smiling doctor and smiling patient on the left, And the words associated with that are, here's a prescription for Zap It, Ms. Jones. Let me know if you have any troubles. By contrast, with rather the grim-looking face of a clinical researcher on the right of the picture and a worried-looking Ms. Jones, and there, what is said, Zap It is a drug that's been used for many decades, Ms. Jones. We believe it might be helpful for what ails you, but we're not certain. Therefore, we're conducting a randomized trial. If you want to be a guinea pig in this trial, you'll need to read this 126-page informed consent form that includes a list of 528 possible side effects. You will also need to sign a legal contract to protect me, the investigators, the manufacturers of Zap It, their stockholders, and our ethics committee from lawsuits should we unintentionally kill you along the way. So the third verdict is the double standard on informed consent to treatment is logically indefensible and acts against the interests of patients and the public. It results in a disincentive to address uncertainties about the effects of treatments. Again, how are ethicists and research ethics committee reducing these problems? Well, in addition to the recommendations that we made for them in that paper, we'll add 2 more now to support those who wish to address uncertainties about the effects of treatments and to promote a single standard on informed consent to treatment. So the overall verdict is, in answer to the question posed in the title of this talk, my conclusion is that unaccountable research ethics committees cannot be trusted to help protect patients and the public. Is my verdict too harsh? Am I out of date? Are the recommendations proposed unreasonable or unworkable? Have the problems and solutions I've been whittering on about since 1978 been solved? Am I overlooking ways in which ethicists and members of research ethics committees are actually being held accountable for their prescriptions, proscriptions, or lack of either of these? Do my vested interests account for my continued promotion of the recommendations in our 1996 BMJ article and in my complaints about the double standard on informed consent to treatment and its adverse effects? Well, my vested interests are as a patient who wants access to effective, safe treatment, and as a citizen who wants more cost-effective investment in research to assess the effects of treatments. And I'm keen to be involved in well-designed research myself. This medical emergency card contains this statement: invite me to participate in any randomized controlled trials which I am potentially eligible. If patients and citizens can't be relied on research ethics, can't rely on research ethics committees to look after their best interests, people themselves need to be helped to acquire the knowledge to defend their interests. We produced, I say we, this is Imogen Evans, a doctor, Hazel Thornton, a breast cancer patient, and I produced a book published in 2006 to try and give people the information they would need to look after their interests. And that was republished in 2011 with an added author, Paul Glasgow, a Australian general practitioner. And it's now in 20 different languages. And the important thing to be said about them, if you go to that website, you can get free for download in any of the languages. And there are also audio books in at least English and Spanish. There may be more by now. That book, when Andy Oxman, a researcher in Oslo, read it, prompted Andy to ask the question, can African primary school children learn how to assess treatment claims? He collected, as you'll see in the middle of this slide, a wonderful team to actually test that idea among Ugandan primary school kids, whom you see all the way around the periphery of the slide. What did we do? It was called the Informed Health Choices Project. I should have mentioned I was very, very pleased and proud to be a member of the team. First of all, identified the key concepts needed to assess treatment claims and illustrated those key concepts using stories told with cartoons in this cartoon book. We then took 120 schools and randomly allocated them either to have teaching with the book or not, the control group. The results were published in The Lancet and reported a large improvement in the ability of children to assess claims about the effects of treatments. And they show that it's possible to teach primary school children to think critically in schools with large student-to-teacher ratios and few resources. That's now in 10 languages and being tested in other places, and you can find out more through that website. While that was going on in Uganda and Norway, a lovely initiative was started in Ireland, started as the Schools Teaching Awareness and Randomized Trials. And I came to find out about this, I think it must have been in the mid-2000s, and something like 2015 maybe. And in 2017, a randomized trial was designed by children at a school who wanted to address the question, does listening to music improve memory recall, or are our parents right and it's a distraction? That was done by Cloggins Hill National School. And here's the team that were responsible for this great idea for a randomized controlled trial. You see Declan Devane, a proud godfather of this initiative. But you know, those were primary school kids. What about children even earlier than that? This statement, "Give me a child until he's 7 and I will show you the man," is attributed both to Aristotle and Ignatius Loyola. And here is Millie Chalmers learning to be a BS detector by reaching up for Ben Goldacre's book, Bad Science, which is endorsed on the front cover of the book by her grandfather. So, what is the basis for the action plans and things that people can do in the light of this evidence? I'm going to take two elements which relate to this talk from this list of actions proposed in this book. First, to promote the research on the effects of treatments, quite simply, and encourage and work with health professionals, researchers, research funders, and others who are trying to promote research to address inadequately answered questions about the effects of treatment, which you regard as important. But only if the proposed research meets scientific and ethical principles. Agree to participate in a clinical trial only on condition that the study protocol has been registered and made publicly available, that the protocol refers to systematic reviews of existing evidence showing that the trial is justified, and that you receive a written assurance that the full study results will be published and sent to all participants who indicate that they wish to receive them. Thank you for bearing with me till the end of this presentation. I leave you with some thoughts from Carl Sagan, the cosmologist, for you to read for yourself while we change speakers. Thank you.
Thank you very much indeed, Iain, for your insightful and quite challenging presentation. I think it's interesting the way a lot of the time we pay attention to the public response to research, but of course we need to shine a light on everyone in the research system and look at everybody's responsibilities. And you also raised the very important question of research waste, which we are really paying a lot of attention to at the moment in the HRB. So we look forward to picking up, I hope, on some of these points that you raise in the Q&A and in the panel discussion. We also really appreciate, Iain, that you stepped out of retirement to share your thoughts with us. So we're really very, very glad that you did. Now, we're going to take a short break to allow you to get a coffee and stretch your legs. And please join us again at 11 o'clock. Welcome back, everyone, to the HRB's conference on trust and truth in health research. And just a reminder again that if you have any questions, you can submit them using the live Q&A, and that's on the right-hand side of your screen. Also, I've been told that the conference is trending really well on Twitter. It's trending #1 on politics. So the hashtag, it's HRBConf2020. So check that out. Now, continuing with session 1, I'm very pleased to introduce our second speaker, Professor Declan Devane. Declan is, to say the least, a man with many hats. He's the Director of Evidence Synthesis Ireland, he's the Director of Cochrane Ireland, and he's the Scientific Director of HRB TMRN, the Trials Methodology Research Network. He's the Deputy Dean of the College of Medicine, Nursing and Health Sciences at NUI Galway, and just in case he's not busy enough, he also holds the chair in midwifery in NUIG. Declan's presentation this morning is titled Thinking Critically About Health Claims.
Thank you to the Health Research Board for the opportunity to speak with you today. I'd also like to acknowledge the humbling experience that it is to speak after Sir Iain Chalmers, who has had and continues to have a profound influence on the lives of many people, and certainly on my thinking over a long number of years. Thank you, Iain. What I'd like to talk to you about is thinking critically about health claims for the next 20 minutes or so. Just some disclosures, although I'd like to think that I've made choices based on reliable information always, I'm confident that I've been duped more than once. My team and I work to help find solutions to how best to think critically about claims. For example, in work we do in the Health Research Board Trials Methodology Research Network, in Evidence Synthesis Ireland and Cochrane Ireland, and in our work around ihealthfacts.ie. This talk today leans heavily on some of our work, and in particular our work with our colleagues in the Informed Health Choices Initiative, which I'll speak to later. And lastly, I think we all have a role in promoting an informed public. I include myself as having a role there, and I also include myself as a member of the public who needs to be informed. Good health, we know, and healthcare depend on people making well-informed, rational decisions about their health and the health of those they may care for. These decisions depend on several factors, including the availability and the accessibility of trustworthy or reliable information about the different options from which they can choose. However, many people feel overwhelmed by information, particularly about how they can improve or protect their own health or the health of those for whom they care. We also know that health information spreads faster and further through multiple interconnected channels of social media, television and radio, the traditional print media, and of course, mobile messaging services. Indeed, the rapid global spread of COVID-19 has been accompanied by what the World Health Organization has described as a massive infodemic. And many of you will have heard and used this term over the past few months, originating, of course, with the previous SARS epidemic. So an infodemic is an overabundance of information, some accurate and some not, that it makes it hard for people to find reliable information when they need it. A lot of the conversations today in the context of COVID-19, we talk about something being, lots of things being unprecedented. And certainly that is the case. But it's also important to look back and see how these same concerns and issues have been raised at many points throughout history. For example, the Dublin-born Jonathan Swift said, "Falsehood flies and truth comes limping after it." And why might this be the case? Why is misinformation so darn adhesive? Why does it stick so well? There are many reasons, and one of those is that misinformation often relies on, for example, sensationalized headlines to help it on its journey. Another is that misinformation is often repeated again and again and again, through those channels we spoke about, and simply having heard a claim repeated makes us more likely to think it's true. And we can see analogies in this in what we might call old wives' tales, myths, or folklore. So, for example, the Irish Folklore Commission Schools collection consists of 750,000 pages of folklore and local tradition collected by 50,000 school children from 5,000 schools in the 26 counties of the Irish Free State between 1937 and 1939. It's a fascinating and rich collection of folklore. And one remarkable thing for me in this is the consistency in local traditions or folklore across the country. This is particularly evident for me in some of the examples of cures for various forms of conditions or ailments. So most of us, certainly in Ireland, will be familiar with the use of dock leaves as a treatment for nettle stings. And that certainly is ubiquitous within this particular collection. But other claims have stood the test of time less well. So, for example, a cure for whooping cough within this collection is noted to pass the affected child in and out under a grey ass 3 times, then get the ass to chew a piece of loaf bread, and before he swallows it, take it from him and get the child to eat it. So perhaps less whooping cough and probably less availability of donkeys in Ireland relegates this claim to the collections of memories only. But more seriously, there have always been health claims, and there always will be health claims. Some stick better than others. However, the difference today is the multiplier effect that social media has on making the spreading of misinformation or unreliable claims much more easy. It's effectively the supercharged old wives' tales or folklore. So, for example, in early March, this photo was circulating on social media, suggesting that Vladimir Putin had released around 500 lines in the streets of Moscow to strongly encourage people to remain indoors during the pandemic outbreak. Of course, that wasn't the case, and indeed this photo isn't even in Moscow. The serious side of this, of course, is that many health claims were made during the COVID pandemic, and some of these have caused serious harm. So many of you will be familiar with examples such as this. The destruction of a mobile transmission tower because of, it was thought, concerns that these towers may have been transmitting or responsible for coronavirus transmission through the 5G network. Of course, we've had claims, as you well know, that sunlight might kill the coronavirus, and suggestions as to how that sunlight might be administered to human beings. And the claims around the diagnosis of COVID-19. So the bottom right of your screen there, which is looking at taking a deep breath and holding your breath for more than 10 seconds. And if you can do this success without coughing, without difficulty, it shows that you don't have the coronavirus infection. So this infodemic affects lives, and people need reliable information so they can make decisions to protect themselves, their families, and their communities. And in an infodemic, people are exposed to spread and some act on unreliable claims that, for example, COVID-19 is a bioweapon, can be treated with ingestion of bleach, or can be prevented or attenuated or weakened by various drugs, potions, and actions. By way of example, in April of this year, the US Food and Drug Administration advised that it had received reports of several people experiencing life-threatening adverse events after drinking chlorine dioxide products arising from misinformation. At the individual level, mistaken trust in unreliable claims and misinformation can and has resulted in avoidable harm, including death. So, for example, patients with cancer who delayed or declined conventional cancer therapy in favor of alternative therapy are more likely to have worse outcomes, as reported by Johnson et al. And the effects of the COVID-19 infodemic aren't just limited to health. They've led to an unleashing of what the United Nations have termed a tsunami of hate, xenophobia, scapegoating, and scaremongering. And we will be aware of the anti-foreign sentiment that surged online in the streets, as reflected in this piece by the Secretary General of the UN. And while it may not be possible to change the amount of information available, improving critical thinking about treatment claims, comparisons, and choices may help people determine and act on trustworthy information or claims and not act on those that are not trustworthy. And one framework to help us do that is the Informed Health Choices Initiative. So this is an international collaboration of researchers led by a team in Oslo. The founding members are Dr. Andy Oxman on the left here, and our previous speaker, Sir Iain Chalmers, and other colleagues. It's a large international network of people who are working together to try and promote critical thinking around health claims. The Informed Health Choice Initiative uses evidence-based key concepts that help people think critically about health claims and make informed choices. The key concepts themselves help people recognize when health claims, and that is the effects of doing or not doing something, are made, to assess the trustworthiness of the evidence used to support the claims, and to make well-informed decisions in choosing what course of action they want to pursue. What I want to do is focus on a number of those key concepts during this presentation. So I'm going to focus on 4 of the 49 key concepts, and they are: competing interests may result in misleading claims, personal experience or anecdotes alone are an unreliable basis for most claims, comparison groups should be as similar as possible, attention should focus on all important effects of treatments and not on surrogate outcomes. So the first of these key concepts, the competing interests may result in misleading claims, or the as advertised principle. The picture on the left is still from the commercial advertising the anti-inflammatory drug Nurofen, which was banned in the UK for falsely claiming that it could specifically target joint and back pain. The second picture from Danone, it relates to a commercial that stated that Activa, eaten every day, is clinically proven to help regulate your digestive system in 2 weeks. Regulators later concluded that the commercials and similar claims on Activa packages were deceptive. Kellogg's haven't been immune to this either. So Kellogg's voluntarily discontinued health claims about the effects of their cereals on children's immunity following concerns that had been raised by regulators. So we need to be cautious that something that is advertised and where there certainly is a competing interest may alter what that advertising message is. The second concept I want to look at is personal experiences or anecdotes alone are an unreliable basis for most claims. The principle that it worked for me. Many people, certainly in the part of the world that I live in, use copper bracelets to help treat the symptoms, certain pain in particular, associated with rheumatoid arthritis. There is little evidence to support its effectiveness, and what evidence is available demonstrates that wearing a magnetic bracelet or copper bracelet does not appear to have any meaningful therapeutic effects beyond that of a placebo for alleviating the symptoms in rheumatoid arthritis. So it's about, just because a treatment works for you or someone you know, doesn't mean it will work for someone else. There are lots of other factors that may have contributed to this particular intervention working. The third concept is comparison groups should be as similar as possible. And we're concerned here if we see dissimilar comparison groups. We need to watch out for comparisons of different treatments where those comparison groups are not alike. For a comparison of treatments to be fair, the people in the comparison groups should be as similar as possible at the start of the study. Were they not similar, it's hard to know how much of a difference in what happened in the two groups was because of that, and how much of it was because of the treatments that they were compared. So, for example, if people themselves decided whether to use a treatment or not, the people who choose to use the treatment may be sicker or may perceive themselves to be sicker or healthier than those who choose not to use it. This could make comparisons of the effects of the treatment really difficult and impossible to know whether the treatment is having a better or worse effect for individuals. The best way to make sure that people in the comparison groups are alike is to decide who gets which treatment by chance, that is randomly. So something like pulling the names out of a hat or flipping a coin. And what you're trying to create in that circumstance are groups that are indeed alike in everything except the treatment that they received. So any differences in outcome between the groups can be attributed to the intervention that one or more of the groups may have received. The fourth key concept I want to talk briefly about is attention should focus on all important effects of treatments and not just surrogate outcomes. And that is about what outcomes matter to you. What expectations do you have? A fair comparison may not include all outcomes, short and long term, that are important to you. Patients, professionals, researchers may have different views about which outcomes are important. So, for example, if we look at this study on the use of apple cider vinegar for the reduction of weight. So if we look at this particular study, Japanese study, the abstract of that paper concludes that body weight, visceral fat area, waist circumference, and serum triglyceride levels were significantly lower in both vinegar intake groups than in the placebo groups. In this particular study, they allocated people to a low dose of cider vinegar, a higher dose of cider vinegar, or to a placebo. But when you bury a little bit deeper into the study, you find the results of the present study show that in obese Japanese subjects who had BMIs ranging from 25 to 30, body weight and BMI were reduced by 1 to 2 kilos and about 0.4 to 0.7 points. That body weight reduction of 1 to 2 kilos was at 4 weeks after a 12-week treatment. So whether or not 1 to 2 kilos over that length of time would be important to you is important to know. What is clinically important or important to you as an individual might be different to something that might be statistically important, which is another of our key concepts. As I mentioned, these key concepts are taken from a suite of key concepts developed by the Informed Health Choices group. I do encourage you to visit the group's website, check and see what they've done. In particular, look at how they have demonstrated that it is not only possible, but successful in teaching children how to think critically about health claims using these key concepts as the basis for an intervention in primary schools. It's well worth looking at, and all of the key concepts are available there. That brings me to the end of my talk. I just want to thank the organisers again for inviting me to speak with you here today. And I'd also like to thank the PPI Ignite group in ANUI Galway, and particularly Deirdre and Anne, for having worked with me in prioritising which of the key concepts might be useful to share with you here today to give you a flavour of the utility of the key concept as a framework for thinking critically about health claims. Thank you.
Thank you very much indeed, Declan. You reminded us, I think, a timely reminder of the role we all play in thinking critically about health claims. And I was interested in your point about outcomes and which outcomes to focus on and the difference between what's important to different participants. And I also very much like your focus on solutions and the concept of a framework to help us deal with health claims. Okay, our final speaker now in this session is Dr. Gillian Murphy. Gillian is a lecturer in School of Applied Psychology in University College Cork. And Gillian is going to talk to us about fake news, false memories, and fact checkers, understanding and combating health misinformation.
Hello and welcome everyone. I'm delighted to be here to talk to you all about health misinformation. I am a cognitive psychologist from UCC, and my main research interest would be looking at what people believe, what they remember, and how those beliefs and memories might shape their behaviour and their lived experience. So obviously this is really relevant to health and never more so than during the current pandemic. So today, to kind of delve into this research, I'm going to ask you 4 questions. I'm going to answer those 4 questions. So the first would be who falls for misinformation? Then when do we fall for misinformation? What happens next after we fall for misinformation? What does it do? And lastly, how do we reduce the impact of misinformation, which is the question on everyone's minds at the moment. So I'm going to jump right in. And our first question is, who falls for misinformation? And by way of answering this, I'd like you to try and answer this brain teaser question. So in a field, there is a patch of weeds. Every day, the patch doubles in size. If it takes 50 days for the patch to cover the entire field, how long would it take for the patch to cover half the field? Now, if you're like most people, there's this voice in your head that's dying to say the answer is 25 days. That is your gut response, because we see 50, we think half, and 25 seems like the right answer. If you slow down and you reason out this question and you really think about it, you'll see that the answer is actually 49 days is the correct answer there. And so this item is an example of a question from a test called the Cognitive Reflection Test. And it's designed to assess our ability to kind of override an initial intuitive response and go with the kind of correct, more reasoned response. And what we find is that across a number of studies is that people who score better in these tests tend to have reduced susceptibility to fake news and for false memories of fake news. So it seems that our ability to kind of slow down to overcome this initial gut response is important, as are a number of other cognitive variables. So in some of our other work, we've looked at cognitive ability, which would just be something as simple as your score on a vocabulary test. That's also associated with susceptibility. But we have to consider other kind of contextual factors as well. So another way of looking at this might be to show you a news story from the abortion referendum in Ireland in 2018. You'll see here, this is a story about the No campaign destroying posters because they were bought using funding from pro-life lobbyists from America. And if you're reading this, and if you remember this happening, and if you can remember seeing this in the news, there's a decent chance that you were a yes voter, because we ran a very large-scale study with the journal .ie during the referendum, where people saw either this story presented as a scandal about the no campaign, or the same scandal presented as happening to the yes campaign. And what we found was that people's false memories and their susceptibility to fake news was more likely to form, these memories were more likely to form along the lines of their pre-existing attitudes. So when you're a yes voter, you're much more susceptible to fake news that makes the no campaign look bad. And this is in line with a lot of cognitive research, and we have replicated this finding in a couple of contexts. So most recently, we have found the same thing in relation to Brexit. So you'll see here an example of a news story where the Vote Leave campaign was accused of election tampering after over 1,000 Remain ballots were found in a skip outside a polling station. Now this didn't happen, this is a fake news story as well, and we presented people either with this story about the Leave campaign or the Remain campaign, and again we see this effect where if you're a Leave supporter, you're more likely to form a false memory that makes the Remain side look bad. And these weren't just passing kind of, oh yeah, that sounds true. People were reporting rich false memories. So you see here an example of someone who said, I think the alleged tampering was over the top. Anyone could have put those votes in the skip. Or someone else on the Remain side saying like, I felt cheated. So what you're seeing here really is that misinformation, in this case, fake political news stories, can distort people's memory of the past. And can have quite a significant effect. But it's important for us to note in terms of answering our first question, when we think of who falls for misinformation, individuals with lower cognitive ability are more susceptible. Those who engage in less analytic thinking, who are more inclined to that kind of reflexive thinking rather than reflective. And also all of us are more vulnerable if the story aligns with our pre-existing beliefs. And these effects are additive, they're not necessarily independent. So, we did find that this attitudinal congruency effect was strengthened when an individual had lower cognitive ability. So these are by no means the only factors that predict susceptibility, but there are some really interesting ones, and obviously they interact with each other as well. So driving on to question 2, when do we fall for misinformation? So here I just want to touch on some research that addresses kind of contextual issues. So if we assume that all of us are susceptible sometimes, what might predict or what might make us more likely in certain circumstances to fall for misinformation, whether that's health or political misinformation or any other kind. So I'll ask you to consider, is this statement true? Critical theft. And what's surprising, and this is a very robust effect, is that if I ask you this statement with a picture of a turtle versus without a picture of a turtle, you're much more likely to think that this is true. And this is called the truthiness effect. And it's simply that when something is presented with an image, even though the image does nothing to help us figure out the veracity of a claim, it helps something to just feel more true. And this has been demonstrated across a number of studies and over a delay period as well. We'd like to think that we all reason kind of independent of things this kind of silly. This is just an image of a turtle. It shouldn't have any bearing on whether or not we're able to work out if something's true. But a lot of the time we are relying on these kind of gut feelings of kind of, yeah, that sounds like it's about true. And just adding a photograph to something, even if the photograph doesn't speak to the claim at all, does increase the likelihood that we will say that it's true. And there are other ways in which something can come to kind of feel true to us, even when it's not. One example of that is illusory truth. So illusory truth is simply the effect whereby the more often you see something, the more it starts to sound true, even if you knew it wasn't very true to begin with. So in a few studies in this context, individuals have been shown news stories like this that at first glance they look at it and they say that's definitely not true. It's not very believable. In this case, a story about Mike Pence undergoing gay conversion therapy. And what I'll show you here is a graph showing that if you see it in yellow, you see the people's truth rating on their first exposure. In blue is how they rated it the second time, and in red the third time. And so what you see is that each time they're exposed to it, it comes to sound a little bit more true. It just starts to feel kind of right to them. And you'll see there on the bottom, in one case they used a warning, and the other condition, individuals were given no warning, and it didn't matter. The warning didn't stop this effect from happening. We'll circle back to warnings in a while. So the more often we see something, the more it starts to feel true to us as well. And so in some of our own recent work, we've been looking at illusory truth effects in kind of different contexts. So one of the things we were interested in was sort of rumors and sort of hearing something and answering hypothetical questions. Does that lead to an illusory truth effect? So what we did was during the last general election, we asked people some hypothetical questions, and one of them was written like this. So would you be more or less supportive of Fine Gael if you heard that since becoming Taoiseach, Leo Varadkar has donated 25% of his annual salary to charity? And this was just asked as a, how would you feel, like a typical polling question alongside some other neutral questions. And some people saw this question, some saw negative questions, there was a mix of conditions. And what we were interested in was we followed people up then either a few hours or a few days later, and we showed them a range of news stories to do, in this case with Fine Gael. We did this with a number of public figures. And in and amongst the true stories were some fake stories. And one of the fake stories was a kind of perfect match to the hypothetical question. So you can see this one here. Leo Varadkar was praised when it was revealed that he has donated 25% of his annual salary to the ISPCC. And this was phrased as a news story. It said, do you remember this happening from 2017? What we found was that initially there was kind of a low level of believability. The story wasn't seen as all that plausible. It didn't happen. So people generally didn't think it was true. But if people had encountered this question, particularly if there'd been a delay and since they had encountered this question, people were 3 times more likely to falsely remember that this had happened. And so here you see that, you know, kind of small encounters that we have with certain pieces of information can all just add to this feeling that something feels true. And the most concerning part with this study was that participants had no idea. So we asked them, we said, okay, you said that you remember this story happened, you've seen it in the news, where did you see it? And they were listing sources. They said, I've seen it on RTE, my wife told me. People were telling us detailed accounts of where they had seen this in the real world, completely unaware that actually it had just been kind of planted in their minds from our study. And so in terms of assessing kind of that second question that I asked, in terms of asking ourselves, you know, when are we most susceptible to fake news, to misinformation of any kind related to health, politics, or any other topic? And we know that we're more susceptible when the story is accompanied by media. It's just more convincing. And also if we encounter the story multiple times in whatever format that might be. So our next question is, what happens when we fall for misinformation? So say someone comes to believe something is true, or they form a false memory that an event really happened. What happens next? If you have read any media over the past few months or few years, you'll know that fake news has been blamed for all kinds of outcomes, like Brexit, Trump. The WHO recently has expressed a lot of concern about the infodemic that has come alongside the COVID-19 pandemic. And so you might assume fairly that we probably have loads of research on what fake news actually does, how it might change people's behavior, maybe how exposure to fake news related to a vaccine might make people less likely to actually go and get a vaccine. But surprisingly, we have almost no research on the downstream effects of fake news. And most studies, including many of my own, we've been measuring, do people believe it? Do they remember it? Are they willing to share the news? We don't tend to try to test these downstream effects. And obviously it's difficult to test the impacts that news might have on behavior, but it's a really important question. And it's a question that we should be somewhat critical of, because I'm sure many of you watching here are health researchers who try valiantly to change people's health behaviors all the time. You put a lot of effort into trying to change behavior, and you'll know that it's difficult to get significant or sustained changes in behavior, even when we throw the kitchen sink at someone with an intervention. So the idea that people would encounter a single fake news story and this will change how they vote or their health behaviors, it deserves some kind of critical interpretation. So in a recent study over the summer, myself and my colleague Kira Green from UCD, we ran this large-scale study with the journal.ie, where we presented people with some true stories and some fake stories to do with COVID-19. This is an example of one of the fake stories here, where we said that the programming team who designed the HSE app, it hadn't been launched at the time, to support the coronavirus contact tracing were found to have previously worked with Cambridge Analytica, raising concerns about data privacy. Now, this isn't true, and we were interested to see whether people would believe it and remember it, which they did, but we were more interested to see, would this lead to changes in people's reported health behaviours? So in this case, their willingness to download the contact tracing app. And what you'll see in these graphs, I hope you can see, is that the effects were very, very small. So what you'll see here on the left is the graph showing those who viewed the story with those who didn't view the story. And you'll see those who viewed the story on the left were slightly less willing to download the contact tracing app. On the right, there's a graph comparing those who remembered that this story happened in real life versus those who didn't. And you'll see again, kind of, they were slightly less likely to be willing to download the contact tracing app. And this was a very large study of over 4,000 people. We were really well powered to detect kind of small effects. And what we found, because we tested multiple different health behaviors, multiple different fake stories, we found inconsistent effects. So not every story had any impact on behavioral intentions. And when they did have an effect, it was like this. It was very small. Now, obviously, this was a single exposure in the context of a study. There's all kinds of other factors that would come into play in real life. But we think this is a really important first step to trying to just quantify what is it that fake news does, because only by quantifying that harm can we hope to design an intervention to combat it. So certainly we think there's a lot more research needed in this regard, and if any of you are interested in collaborating on this, we'd love to hear from you. We think we need a lot more data on how exactly what these downstream effects of misinformation actually are in the context of health. So my last question then was, how do we reduce the spread and the impact of misinformation? And there are multiple approaches to this. Lots of you will be familiar with various kind of fact-checking organizations like Snopes or the journal.ie do this as well. And fact-checking is really important, and it certainly has an important role, but it doesn't necessarily help to reduce belief or sharing of misinformation. So Facebook a couple of years ago attempted to run an intervention where when people share the story that they, other sites had found to be fake, they gave people a little warning, and they hoped that this would reduce people's sharing of misinformation. But in a lot of cases, it actually just made it worse. It strengthened people's beliefs in it, and it had a lot of unintended consequences. And this story kind of underlines how important it is that we actually go and test these interventions, and a lot of these effects in this area that seem very intuitive and we think make absolute sense don't really work. And so another example of this would be warnings, just general warnings. So not attaching a warning to a specific study, but just generally kind of raising awareness, encouraging people to look out for fake news. You see a lot of these campaigns. I'm sure most of you have seen one before. And on the HSE website at the moment, there's a whole section on kind of how to approach sources and how to find reliable information during the pandemic. And we might think that this would work, but again, we have almost no evidence on it. So very little research testing these general warnings, seeing does it reduce people's susceptibility. So as part of that study that I mentioned with the journal.ie, we tested this approach, and it kind of follows an inoculation metaphor whereby we think we'll warn everyone about fake news, and then afterwards they'll do better. They won't be so susceptible. So we expose people to, we just asked them to look at a couple of public health posters. So this is an example of one of the control posters to do with washing your hands. And we asked people, how many times have you seen this in the last week? So we just wanted them to read them and interact with them like they normally would. And some of the posters they saw were related to fake news. These, very similar to these kind of public information campaigns. And we tried versions that were worded kind of positively. We tried ones that were framed more negatively. And then we had a series of control groups as well. And to cut a long story short, the wordings did nothing. They had no effect on fake news belief, no effect on false memories, and no effect on the related behavioral intentions. So reading a warning about fake news didn't stop that reduction in willingness to download the contact tracing app if they saw the story about the contact tracing app. And this is perhaps not all that surprising that these warnings don't work, because if you cast your mind back to the start of my talk where I mentioned that problem about the weeds and the difference between reflexive and reflective thinking, most of that research would suggest that we are capable, most of us, of discerning a lot of the time between reliable and unreliable information if we really try. But most of the time when we're consuming information online, like if I'm a patient and I'm looking up information about my health condition, I'm not going into it thinking, is this accurate or is it not accurate? I'm going into it with other questions. I might have kind of emotional needs, or it might be, I might be in a social kind of frame of mind if I'm in a support group. I'm not going into it thinking that my job is to evaluate accuracy. But the idea is that if we could encourage people to do that, if we could nudge them into a frame of mind where they are thinking about accuracy, they might be actually able to do it. There's a couple of studies that have shown some promise with this. So in this study here, people were either asked before they viewed some news, they were asked, is this story accurate? Just asked to make an accuracy evaluation, or they were asked, would you share this news story? And what they found, as you can see here, the y-axis here shows people's willingness to share a story. When people underwent this accuracy intervention, when they were nudged to think about accuracy before they viewed information, they became less willing to share any fake information, and it didn't impact their sharing of true information. So this is one of kind of a couple of promising intervention methods that suggest that maybe if we look at kind of these evidence-based solutions to encouraging people to apply the abilities that they already have, we might be able to better combat misinformation. Because, another thing I didn't mention there is that fact checkers can't keep up. It's much quicker for me to create a fake news story and share it everywhere if I'm a bad actor than it is for a fact checker to have to combat that. So, it's more economical to, if we can empower patients and members of the public to just be better able to discern true from fake information, and kind of encourage them to apply that skill kind of by nudging them in that regard. So in summary, misinformation is powerful. It can distort our memories. We need a lot more research into the downstream effects of misinformation, and some of that research is ongoing. Susceptibility to misinformation can be increased due to individual differences and also due to some situational factors. And finally, we do need to develop solutions to target cognitive skills rather than relying on fact checking. So we are undergoing some research in that regard at the moment, some of which is funded by the HRB, and we're really excited to see what we might find in that regard, but very open to collaboration. So I'd love to hear from some of you if you want to get in touch about following up on this a little bit more. Final thanks to all my co-authors, especially Ciara Green from UCD. We do a lot of research on this together, so most of these studies were done with the two of us, and also to the journal.ie, who have been a wonderful partner in assessing these kind of evidence-based solutions, and we're really glad to work with them. So I'm happy to take any questions or get in touch via email. Thanks.
Thank you very much indeed, Gillian. That was a really fascinating talk and a really interesting angle, how people form false memories and how that can impact health behaviours. I'm sure it's going to give rise to lots of comments and questions. And I especially like the concept of truthiness. I might roll that one out at some stage. Okay, we've heard now from all our speakers in the first session, and we're going to move on to the panel discussion. So I want to welcome to the screen my colleague in the HRB, Dr. Teresa Maguire, who is Director of Research Strategy and Funding here in the HRB, and who is going to moderate the discussion. So Teresa.
Thanks very much, Mairead. Delighted to be here this morning virtually with all of you. And really delighted and particularly privileged to be asked to moderate this panel discussion with the infamous Sir Iain Chalmers and our other guests. Indeed, I don't know about the rest of you, but I'm still kind of pinching myself that I'm actually having this discussion sitting in a corner of my bedroom. Just goes to prove we're living in very interesting times, and perhaps every cloud has a silver lining. Wherever your makeshift offices are at the moment, you've been busy firing questions in and comments and voting and so on. And thanks very much to all of you for doing that, because this is all about having the dialogue around this really important issue. Without further ado, because time is limited in our panel discussion, we have from now till just 12 o'clock. And I'd like to welcome back our speakers to participate in our panel discussion. So I'd like to welcome Sir Iain Chalmers, who has spoken to us quite provocatively, I think, about the role of research ethics committees and their role in protecting the trust of the public and patients. Declan Devane, who spoke to us about a framework for thinking critically about healthcare claims, and most recently Gillian Murphy, who has spoken to us in a very thought-provoking way about misinformation and a new take on fake news, certainly for me anyway. So without further ado, if the panel members are okay, we'll get straight into the questions. It won't surprise you, Serene, that there were numerous comments, not even just questions, saying thank you for joining us today, that it was an inspiring, as always, talk and hugely provocative. And I'm going to start with a question or two for you in response to the many questions that came in relation to that. If I can start with the first question, which came in from Chris Noon initially, which is asking, how would we go about educating our ethics committees about the ethical issues around power calculations and underpowered research in particular? Most ethics committees request information on this, and I suppose most people at the other end of it know it can be quite tricky to do a good power calculation. But how can we take that forward, or what can we do to educate and maybe improve our ethics committees in this space?
Can you hear me okay?
Yes, we can now.
Yes. Okay. So the question about power calculations is actually quite interesting. In essence, what they're intended to do is to ensure that a study is going to be large enough in terms of the principal outcomes expected to give a statistically reliable estimate of an association. Now, that involves guesswork. It involves guesswork because although you may have estimates of how frequent the main outcomes are going to be, you don't know whether those estimates are actually going to be borne out by the experience of this new trial. Let's call it a trial for the time being. Other types of studies it'll manage as well. So you do your best to try and ensure that you have a study which is large enough. And by large enough, I emphasize, I'm talking about outcomes, not about the number of people involved in it. Because if, for example, you have, let's say, a randomized controlled trial with 1,000 people in each group, in each of two groups, but there are no outcomes, then it has zero power, despite the fact that 2,000 people have participated in it. So you need to concentrate on what you should be measuring to make, anyway, an estimate. Then you're going to have to make an assumption about how big a difference you expect to be able to pick up from a study of a certain size. And it is an estimate. You don't know whether, in fact, let's say the difference between two treatments is going to confirm what has been shown previously in studies addressing the same thing. It's a guess. Now, the point that I'm raising these issues for is to emphasize that there's an awful lot of guesswork in power calculations. So the question that I would say is probably as important, if not more important, to focus on is whether it's worthwhile doing the trial at all. And the reason I say that is that, let's say it's a relatively small trial. Let's say that, in fact, there are already some studies which have looked at hundreds, if not thousands, of patients. And you want to think in terms of doing an additional trial. Well, first of all, you've got to have a good reason for doing that. Let's say, for example, that in the previous studies, mortality hadn't been studied as an outcome, and you want to actually contribute information that would allow one to come to judgments about the appropriateness of the study that's going to be is being proposed to fill that gap in information. Well, it may be one of what may be a number of relatively small studies. But as I showed in my presentation, you can take small studies, and as long as all of them have been published and have been well designed, you'll be able to use the information that they have generated to help get an overall feeling for in that case, a difference between two treatments or some other sort of estimate. So what I'm saying is, be cautious about what power calculations can and cannot deliver, but also be aware of the fact that relatively small studies, well done, well designed and well done, can contribute useful information. And not, as some I've read, I think it was in the Journal of the American Medical Association, where a statistician suggested that it was actually unethical to do a study which was underpowered. Well, the alternative is you don't do any sort of control studies. Now, faced with no useful information at all, because an ethicist has said that you can't do a big enough study, compared with doing a small, well-designed study which could contribute to a body of information, I think shows another danger of relying on what ethicists believe is the right way of looking at things. Sorry, it went on for a rather long time, but I hope that gives some idea, at least about what I think about these matters.
No, I think that's an equally intriguing response and a very thoughtful response in follow on to that. And look at that, and I appreciate it was not a difficult question to answer lightly, but it was our top trending question. So therefore, for the rest of the panel and everybody, thank you for bearing with me in relation to that. I'm delighted with the response. I'll give Serene a break for a minute, because I will come back, because there's I can warn him, there's a bit of discussion going on as whether this is just the role of research ethics committees, or is it actually more the role of funders? Some people asking, is it the role of journals? So I'm going to come back to you in a minute in relation to that, and probably as we wrap up. But Declan, maybe if I could ask you've got some people asking questions, I suppose, in the sense of, well, what is data versus when are anecdotes potentially data? And in particular, if there are numerous anecdotes from patients, should they be discounted? Are they not data? And is data only the preserve of randomized controlled trials? I wonder if you'd say something about that.
That's a good question, and I think that speaks to the core of what I was trying to impart, is that it's being able to discern the difference. It's being able to at least identify what is the source of that information and the potential reliability of that information. And people can then take a judgment as to what decision they want to take based on their assessment of the reliability of that evidence. But the challenge we have with misinformation and disinformation is we have information being purported as fact, when in actual fact it may not be. And we have other information that, by most assessments, is reliable information being subsumed by that avalanche of mis and disinformation. So I think all evidence has value, unquestionably. I think when we're looking at the effects of healthcare treatments, I think that issue, which Iain and colleagues have coined many years ago, the need for fair comparisons, so the need for randomized trials, is the ideal way of generating that evidence. And I think we need to at least consider conducting those trials where it's possible to do so, and considering carefully when we're making claims that it's not possible to do so. Picking up on Iain's point earlier, I think it speaks to that. So a good example. So an example that sticks in my mind quite convincingly is an intervention, which is a simple intervention used in healthcare that reduces mortality, and that is the administration of steroids to mothers antenatally, for mothers who are at risk of preterm birth. And we have some really good evidence this is a very effective intervention. And that evidence largely stems from not any individual trial, but the synthesis of a number of well-conducted trials or fair comparisons. So that speaks to, I think, that the issue around that individual studies that are well done, as Iain said, that are underpowered, can still add value. That's a really good example of where it's made a substantial difference to the lives of many women and their families. Not for a second dismissing the different sources of knowledge that people use to take decisions. I think one of the real challenges we have is in differentiating what those different sources of knowledge are and which might be reliable given a question that we want answered. In the context of asking a question around the effects of healthcare interventions, I do think there is an absolute need for and a role for fair comparisons. If they are not being conducted, we need to ask why. Can they be conducted? And if they're not available, we have to take a decision based on the best available evidence that we have in front of us.
Thanks, Declan. And I think that helps us segue into some of the issues that Gillian was discussing in her talk as well. And Gillian, we have a question that was asked by somebody working in communications in a public health agency. And I suppose they're asking you, do you think that as a community, as a society, but particularly for decision makers and healthcare policy makers and researchers, that we do enough to communicate our work beyond the usual conferences, journals, and so on? And I suppose they particularly were talking about blogs, podcasts, media, and so on. And where does that come in this overall conversation?
Mm-hmm. Yeah, so I have a particular interest actually in science communication. I work a lot with FameLab Ireland, and FameLab is the world's largest science communication competition, and researchers get up and they explain their research in 3 minutes with no slides, and you communicate what you're doing to the public in kind of a storytelling kind of way. And I run training for that sometimes, and I work with FameLab, and kind of through my work with them, really, you see how maybe partly the way a lot of researchers are trained, people sometimes think of that kind of work as extra, as just this kind of thing to the side, something they don't really need to do. They might do as kind of a tick on a CV. Not all researchers, of course, but a lot of people can kind of see it that way. And then I find when they do the training and they go through the process, often they'll gain so much out of it in terms of how they look at their research, because instead of thinking, okay, what am I doing with my research in terms of getting it published, or what will people in my field think about this, often engaging in kind of what more widespread, more democratic scientific communication, you get to take other perspectives on board, and you think about a different audience for your work and kind of what you're doing. So I would be a strong advocate of people engaging in that a little bit more responsibly. And I think one of the biggest challenges in this area is communicating uncertainty. So a lot of the time, what we're finding in misinformation research is that we don't know. And it's difficult to write articles or give an interview where a lot of your conclusions are, we don't really know. And that's important, but we're seeing it a lot with the COVID-19 pandemic. I think some of the best communicators we've seen in Irish media manage to communicate that uncertainty and to kind of describe that scientific process. So definitely, I think we should do more of it, but I know a lot of people are doing great work in the area.
Thanks, Gillian. And back to Serene, it won't surprise you in your provocative talk that you've got a lot of people thinking, and particularly a lot of people who are participating on ethics committees, and there's I suppose questions coming to you in the sense of, do you think that it's largely because we have a voluntary and often a fragmented research ethics committee system that we're perhaps not quite getting the accountability that you described, and if we were to, in a sense, do something about that, perhaps even pool those voluntary resources, it might drive up better standards. And then others who are really saying, actually, well, is it really right to blame research ethics committees and their members, and is it not really more for funders and perhaps governments to stand up and to try and resolve this issue?
Okay, well, that question has really quite a lot of ramifications, and so let me try and deal with them. The first thing to say is that of the various actors in all of this, the research ethics committees are established specifically to look after the interests of the public as seen from ethical points of view. The journals don't have any such mission. Neither do the researchers themselves, nor the funders of research. So they have a very important position. And I ought to make clear that I served as a member of a research ethics committee in Oxford for 4 years. I'm completely convinced that the people on that committee did their best to make judgments that they were expected to make. What I'm less confident about was neither I nor other people on that committee had been tested to find out whether we knew some of the basic things that we should be looking out for. There's a sort of curious idea that people who are appointed to chair or be members of research ethics committees de facto operate from a position of moral high ground. Now, how on earth could that be justified without actually testing some of their moral positions? I don't think it can be, and indeed, I'm involved with some Australian colleagues at the moment in looking at answers given by members of research ethics committees for questions relating to whether or not certain types of study should require ethical oversight or ethics oversight at all. And some of the answers to these questions basically reveal profound ignorance about some really basic things. And so it worries me that there should be an attempt to shift responsibility for looking after the interests of the patients and the public to some other actors. For example, you can't say that it's going to be something which the journals will sort out, in the knowledge that about half of the controlled trials done don't get submitted to journals. If, for example, and indeed those that do get submitted, one that I learned about a couple of days ago was quite a large controlled trial comparing mask use compared with not mask use, but social distancing in both groups. Big trial, didn't show statistically significant differences between the two groups, has already been rejected by 3 journals, almost certainly because it had a so-called negative result. Now, those are irresponsible decisions, but journals are completely free to make them. And so we can't look to journals to sort this out. We can't look to funders necessarily, because some of them have very large vested interests in getting certain types of results from their studies, because they have a commercial or some other sort of interest in the results of the research. So the research ethics committees really do have a very important role, but at the moment they're behaving in some respects in ways which suggest that they don't see just how important their role is and how it should be informed by an understanding of the issues. I've made absolutely no impact in 52 years of wittering on about this topic. So I've got to leave it to other people, certainly the next generation, to see whether this is something they can get any progress on, looked at from the point of view of people like me who are patients now. That's my main interest in all of this, is to get better research. I don't know if I'm leaving too many elements of that question unanswered, but come back at me if you think I am, and I'll try and do better.
Great, really appreciate that answer, and it's just perfect timing. I think particularly, I mean, clearly this is a global issue, but in an Irish context, probably for the first time, we're looking at trying to set ourselves up, improve, and resource our very under-resourced and fragmented research ethics committee system. So it just couldn't be better timing. I know that we're kind of sort of already out of time, but I can't finish this panel discussion without asking what is now our sort of top trended question, which won't surprise you in the context of COVID. And I suppose I will ask it of each of the panel members, but maybe ask you to be really, really brief. If you can even say yes or no, that would be even better, but you may not be able to, but please keep it as brief as you can. But I do want to just get a sense of it. The question comes from Molly Byrne, and it's basically asking each of the speakers, will they be making an informed choice to get a COVID-19 vaccine when one is available? And should the public be sceptical about the quality and or the speed of the research which has gone into the vaccine development? Declan, well, I start with you. Put you on the spot.
Thanks, Teresa. I will be expecting to see the information fully and transparently reported about the process that's being used to develop the vaccine, to include its safety and effectiveness, to include its regulatory approval processes, and so that I can make an informed decision. And I would hope that that's done in parallel with an effective communication strategy, whereby we bring the public with us and give them the information on which they can take an informed decision.
Thanks, Declan. Good use of your framework there. Nice segue into your answer. Well done, but really interesting. Gillian, can I ask you to maybe give your perspective?
I would absolutely agree with what Declan said there. I think I know myself as a patient, my experience as a researcher feeds into how I behave as a patient. And as a patient, I just want all the information I can get my hands on so that I can make an informed choice. And so I think that information being made available, it being transparent, and maybe leading the public on conversations around how to evaluate this kind of research and how to kind of parse the uncertainty that will come with it. And there's been a lot of talk about narratives and storytelling and kind of bringing people through that process rather than in a kind of dictatorial way, just telling people you must get a vaccine and you're irresponsible if you don't. We know that doesn't work. So certainly I think there's a real role for Irish researchers in kind of making those conversations and those reflections as public as we can. But yeah, I do anticipate I will be getting a COVID vaccine.
Thanks, Gillian. And fittingly, I think if I can ask Serene to have the last word in this morning's session in response to that question.
Okay, thank you. Earlier this year, in February, I diced with death with community-acquired pneumonia, not COVID, but community-acquired pneumonia. And it was a pretty close-run thing that I got through it. It was a horrible experience. I want to be healthy enough to deal with COVID if it catches up with me between now and when vaccines become available to people in, as it were, my category. I'm old, I'm 77, so that gives me one thing. But in the meantime, I want to be involved in research, in practice, certainly, social distancing and so on, washing hands obsessionally. But I also would like to participate in controlled trials of promising ways of reducing infection. And one of them, I don't know if you can see this, it's called povidone iodine. And what it does, it's very widely used for people who are scrubbing up prior to doing a surgical operation. It's a disinfectant and it's virucidal, it kills viruses. Now, diluted, there are some trials going on using dilutions of this to nasopharyngeal spray and gargling before you go into an area like a supermarket where there's an increased chance of becoming infected. I would like to participate in a trial which finds out whether this does more good than harm. Because in the time between now and when vaccines become available, we've probably got 4 or 5 months. There should be no reason for not doing this trial. The main disincentive is no one's going to make much money out of it.
And on that note, and with lots more questions, I think, going through my head necessarily than answers, picking up on the point of uncertainty there, I just want to thank our speakers today for a really coming at it from such a range of perspectives, really illuminating, like I said, really thought-provoking. Apologies, we've gone slightly over time, but I think you'll agree with me that it was worth every second of it. So thank you very much to the speakers. Thank you for the panel discussion, and thank you all for sending in your questions and voting so on. Otherwise, it just would not have been as an illuminating an affair. So I'm going to hand back across to Mairead, who's going to close out this session and tell us about the rest of the conference, particularly that this afternoon. Thank you.
Thanks very much, Teresa. And again, my thanks as well to our speakers, Iain Chalmers, Professor Declan Devane and Gillian Murphy, for your really good thought-provoking presentations, and indeed for the excellent panel discussion. And thank you to everybody who joined us this morning and who submitted questions. Keep them coming throughout the day and indeed tomorrow. And I noted that as well as our excellent speakers, we were joined in spirit along the way by Robert Boyle and Jonathan Swift. It's been an excellent morning all round. Now, a reminder to everyone that the session is available on demand on the conference platform directly after this live session ends. So if you just want to listen back to anything, it's there. Okay, we're now going to break until 3 o'clock this afternoon, when we will come back and restart for the second session, which is all about assessing the credibility of health claims. So much more to come here at the HRB's conference on trust and truth in health research. See you all then.